Hmm. All right. Well, today we have Delisha Carpenter. She is going to be talking about some of the barriers to MOUD access and rural community pharmacies. Hey, we've all been there. What a mess it can be sometimes. I'm Kurt Devine. I think we can all see Erin Foss, and everyone should know her. So, next slide.
All right, we have some wonderful upcoming talks on the old schedule. So Jordan Kazor, he is a doc that works in Hibbing, Minnesota, and he recently gave some of his partners some education about like opioid stewardship and like making sure diagnoses were correct with opioid prescribing and looking at the whole person approach in opioid prescribing. So I think what he's going to be talking about are snippets from that or something around that topic. And then Nathan Caranda from Your Path is going to be doing a discussion on the mental health components of addiction medicine care. And it looks like June 25th, we have a talk coming up on the opioid settlement funds dashboard, which I didn't know even existed, but it's a really neat tool that I'm excited to learn more about just to see where counties are allocating funds and if we can identify some gaps or be at the table when those decisions are being made. Also,
Yeah,
there's other Echo series happening as well, so check those out if you haven't taken a look at those. They're listed at the bottom of the screen.
Yeah, the May 28th talk is going to be replaced because of some timing issues, but we're going to be bringing on Cole Perringer and Dr. Corser from Bemidji and myself, and we're going to be talking about the grant money that we have and what we're doing in the emergency departments and run through some of our ED protocols that we've developed. We're all doing things a little bit differently, so it should be fun. There's going to be some cases involved with that. So we're actually doing this in preparation for the rural health conference, which we're going to be speaking at. So May 28th is a little bit different than what is listed. Remember, there's free CME. All you got to do is listen to Katie when she sends you that email. So please fill that out if you want the CME. Make sure you think about, or at least consider turning on your video because our speaker today would love to see your face and not a black box. So we like to think everybody can just flip that switch. We don't even care if you're eating. Go ahead and eat. No one cares. I'm in a syrup shack boiling maple syrup. You can eat. No big deal.
You should have dipped your cookie in there, Kurt.
Mm.
That would have been good. All right, just keep in mind that we are always here for your technical assistance needs. If you have any difficult cases, just need an ear to listen or run something by policies, protocols, pretty much anything. Don't reinvent the wheel. Just give us a shout out first to see if we can help you along.
All right, and remember, you can go on the internet and look at the core website. It has all kinds of fun stuff from different protocols and different ways that we've done things in the towns program and so on. So feel free to check that out if you need some info. All right, and with that, we will move to our speaker. And Delisha, if you'd like to kind of give a little introduction for yourself as well, a little bit about what you do in real life, and then are you going to share your screens, or do you want Katie to run everything for
Oh,
you?
yeah, I could share my screen.
Okay.
But yeah, I'll just start with introducing myself because I can see you all this way before I share screen and then I can't see you anymore. So it's a pleasure to be here. Thanks for inviting me. I am a professor in pharmaceutical outcomes and policy at the University of North Carolina Eshelman School of Pharmacy. I'm actually based on our satellite campus in the mountains of Appalachia out in Asheville, North Carolina. So coming to you from 1 hour in the future, since you're 1 hour behind us. But it's nice to join you. If you happen to see the University of Vermont talk that I gave on the same topic, it's almost the same, but hopefully the information in it will be useful to you. And I'm not taking up the full total amount of time. I usually like people to interrupt me as I'm moving along and on the slide that you're interested in what I'm talking about rather than waiting to the end. So feel free to interrupt me, come off mute, ask a question, and hopefully we'll have a good discussion around this. So let me share my screen. I've got to share video and audio because I've got a video in here. All right, can you all see that okay?
Yep, it's in presenter mode now. Perfect.
Okay, great. Well, so yes, we'll be talking about addressing barriers to MOUD access at rural community pharmacies. This is something that I've been studying for the past 8 years. We've done a lot of research in it in North Carolina. I got into this space, even though I'm trained in public health and I'm not a pharmacist. I'm here because I lost 2 friends to opioid overdoses about 2 years apart. Many years ago. And so I've just gotten really into the harm reduction space and making sure people have the resources that they need. So we have 4 objectives that we're going to go through today. Mostly be talking about barriers that impact MOUD dispensing in rural community pharmacies and how that impacts patients in rural areas. We'll talk about resources that we've developed here that can be used to increase MOUD access at community pharmacies, though these resources could be used just about anywhere. And then, assuming that there's a lot of prescribers on the call, we'll discuss specifically how prescribers can work with rural pharmacies to support MOUD access. I do want to just give a brief background on pharmacists in the harm reduction space and the MOUD space. So, and point out that pharmacists are impactful and they're accessible. So we know that pharmacists provide medications for opioid use disorder, harm reduction supplies. Naloxone's been around for a long time. Buprenorphine, non-prescription syringes, and drug test strips are something that they're starting to sell in various pharmacies, depending on what the state laws are. Also, if you're not aware, there was a recent paper published in JAMA earlier this year that looked at naloxone distributed via pharmacies in the Massachusetts statewide standing order and found that that pharmacy distributed naloxone was associated with decreased opioid overdose death rates. So getting things out into the public sphere through pharmacies has been impactful. Pharmacists also implement screening and counseling services for people with opioid use disorder and offer drug take-back programs. And there's a lot of other things that pharmacists do, but we won't get into all of that. You may have seen this map too. So this is showing the percentage of the population that lives within 5 miles of a pharmacy. Anything you see in dark blue there's 100% of the population living within 5 miles of a pharmacy. Anything in dark red, there's 0% of the population within 5 miles of a pharmacy in those counties. So as you can see, there's a lot of blue on this map. That may be changing, as you may have heard in the media recently about pharmacy closures and pharmacy deserts, but this is the most updated data we have on pharmacy access. And so that basically translates at the time, which I believe was 2022, 90% of the population living within 5 miles of a pharmacy. But the main reason that pharmacies are accessible, there are over 60,000 of them in the United States, or they often have evening and weekend hours, and you don't need health insurance or a doctor's appointment to go speak with a pharmacist. So that does make them accessible. Sometimes in rural communities, they're the only trained health professional in a very tiny community. So just something to be aware of there. So let's dive in and talk about barriers to MOUD access at pharmacies, which you've probably also been hearing about. I am going to focus particularly on oral tablet and film versions of buprenorphine, since this is what's been available at pharmacies for the longest period of time. But I do want to bring you up to speed on some developments around methadone and naltrexone. So for methadone, you may have heard of the MODA, the Modernizing Opioid Treatment Access Act. If that is passed, and there's some suspicion that it will, it'll allow various practitioners to e-prescribe methadone directly to pharmacies. So I just want you to know that that is on the radar if you aren't already aware. And then already in some states, there's medication unit partnerships with pharmacies where opioid treatment programs can partner with pharmacies for dispensing of methadone. So that's what's going on in the methadone space. You may have heard that pharmacists are also getting increased scope of practice as it relates to long-acting injectables. So for naltrexone, pharmacists in Wisconsin and Ohio can administer Vivitrol. And they can do this in other states as well if they have collaborative practice agreements. So we're seeing more and more states give pharmacists the scope of practice. So you'll see that more often. You're also going to see more Sublocade and Brixadi being administered at pharmacies. I was just on the phone this morning with Indivior. They have this patient injection network across the United States. Albertsons in particular are where pharmacists are giving the Sublocade injections. So you're going to see a lot more of that in the pharmacy space. But like I said, we'll focus on buprenorphine moving forward from this point. Just to give you a high-level overview of barriers to buprenorphine access at pharmacies, they're at these different levels of the social ecological framework, and this is a lot that has come out of our research where we've been doing interviews and surveys with pharmacists and other stakeholders in North Carolina. So at the policy level, there's suspicious order monitoring programs that are implemented by pharmacy wholesalers that leads to pharmacy thresholds on the amount of buprenorphine that pharmacies can dispense. Also, each state often has their own red flag policies and legislation that says that these are red flags for controlled substances that can limit dispensing at the pharmacy. At the provider level, we know that there's limited substance use disorder treatment options in rural areas, which limits access for patients. And then also pharmacists and providers report a lack of communication with the pharmacist. At the pharmacy level, we see refusals to fill, stigma, lack of communication with providers, mistrust of prescribers and patients, and then misinformation about buprenorphine. At the patient level, they talk to us about dispensing delays, stigma, cost issues, and transportation. And as I go through this presentation, I'll be sharing some survey data and actual quotes from our interviews that we've been doing with folks in this space. So overall, like our main findings so far have been that three main things contribute to a buprenorphine bottleneck in our state, where there's more people wanting to get buprenorphine than are actually getting buprenorphine. And those things are increased prescribing, stigma, and wholesaler thresholds. So we do see this prescribing cliff in North Carolina, where more prescribing doesn't necessarily result in better access to buprenorphine. I want to start with stigma. This is a pervasive issue that has been across every harm reduction resource that I've studied at pharmacies. So we see it with non-prescription syringes. We see it with medications for opioid use disorder. We see it with naloxone. So again, this is a big issue at pharmacies, but we found that a lot of the stigma is actually caught up in misconceptions about substance use disorder and opioid use disorder treatment. So I'll give you some examples around that. So these are quotes. This is a pharmacist that's been practicing for 10 years. So they seem to start taking buprenorphine to get off opioids, which is good, but they never seem to get off the buprenorphine. So they're kind of trading one addiction for another. I can't tell you how many times I've heard that exact language when talking with pharmacists that, you know, that's great that someone's on medication, but they're basically just substituting one medication for another, trading one addiction for another. So use of that stigmatizing language. Also, a second quote, you mentioned another pharmacy in town that will not fill buprenorphine. Why? Our technician who used to work there just said, the pharmacist just doesn't want to. She's trying to prevent certain people from coming through. She doesn't sell needles or any kind of bupe. I think it's more, I guess, just maybe ethical or moral. She just chooses not to. This is something that we see a lot. Pharmacists are often afraid to have people with substance use disorders come into their pharmacy. They're afraid they'll overdose in the bathroom. They're afraid that they'll dissuade other customers from coming in. So there's a lot around that. And we're doing a methadone survey right now with North Carolina pharmacists. And the second biggest barrier to pharmacists being able to dispense methadone is that they don't want to attract people with substance use disorders to their pharmacy. So again, a major issue that we need to address in our state, but I've heard about this in other states as well. And you may have heard this from your patients who go to pharmacies to pick up buprenorphine. But tying into the misinformation about buprenorphine and OUD, So with pharmacists that we've interviewed, half of them have mentioned perceived diversion as an issue. And if you're not familiar with pharmacists, they're very concerned about legal issues. They don't want to do anything legally that will get them in trouble. So they do get nervous about diversion. So here's an example quote. We restrict them with controls, not because we think they're abusing it, but we don't want to take the chance. So they don't even want to take the chance of diversion. And so that can make them less likely to dispense. We try to educate them about reasons behind diversion from the patient perspective. So if you look on that right box there, you talk to people who have used diverted buprenorphine. They're primarily using it to prevent withdrawal and maintain abstinence from illicit substances. So the reasons that they're using diverted buprenorphine are not nefarious. If you look at the middle box, 81% prefer using prescribed buprenorphine when they're able to get it. And then on the left box, 33% who'd used diverted buprenorphine reported barriers to finding a doctor or obtaining buprenorphine on their own. And we'll get into some quotes later where people have experienced dispensing delays and are starting to go through withdrawal. And so they're trying to get a hold of something that they don't end up going through bad withdrawal from buprenorphine. So this is something we try to educate them about in the training that we've developed. Another thing that comes up pretty frequently is concerns about how long somebody is on buprenorphine, so the treatment duration. They want to see tapering in patients over time, and they want to know what the provider's intention are around a longer buprenorphine prescription, and they seem to have misinformation about evidence-based practice in this space. So here's an example quote from a pharmacist who's been practicing for almost 40 years. So I worry about the length of time somebody needs to be on the buprenorphine, but I guess it's a medical question. We're glad to dispense, but again, the purpose is to get them off of drugs. Seems like they could be off that one too eventually. I'm just concerned about people being on it for, 10 years. You have to weigh the cost to society. It's better then to do that than be on black tar heroin, I guess. I wonder how long. It seems like they could taper off of this. I don't know, after 3 years. Seems like a lot of people don't ever get off the buprenorphine. They're on it for years. And so we heard that pretty frequently as we were talking with pharmacists in the state. In our interviews, we also talked about unwillingness to dispense and what the major causes of that were. Most commonly, and this is a red flag in the state of North Carolina, according to our STOP Act or opioid legislation, but if the patient's coming from out of the area, that's the main thing. So if someone's coming from out of the geographic area, it's a red flag that makes them unwilling to dispense. I mentioned pharmacy closures earlier, and I can tell you out of our 100 counties, we already have 2 that have no pharmacies, no community pharmacies in the state. So by definition, if anybody is prescribed buprenorphine in that county, if they're going to get it filled, they're going to be going outside of their geographic area. And so that shouldn't be a red flag in that situation. They also have mistrust of prescriptions. We saw earlier, like maybe they think that they're going to be on it for too long or for particular types like monoproduct prescriptions. They have reported just not accepting new patients for buprenorphine, and I'm going to talk to you about the wholesaler thresholds that can create that. Also, a lack of product when they're trying to get it. So here's a quote around this. We do have to look at it, the people we're serving. Are we serving just people inside of our county, or are we getting people from outside? And we do have a couple of folks who, and I don't even remember how we ended up with them, but their doctor is in a different county. And, generally we don't do that. Just they can't find anywhere else to get their medication. It's not any question as to whether they're legitimate prescriptions or not, but they come here from the next county over, and it could be very problematic. We usually just try to take care of people who are really close. And we'll see that where they'll prioritize dispensing to people who are within the county. When we dig in more, this was a survey study we did, over 500 pharmacists in the state talking about their buprenorphine dispensing practices. The good news is that 96% reported keeping buprenorphine in stock. However, patients who had pharmacists who had more negative attitudes towards buprenorphine were less likely to dispense. And just because they have it in stock doesn't mean they're always dispensing it. So 62% have refused to fill a buprenorphine prescription, with 55% refusing to fill at least 3 times. So that's 3 times for hundreds of pharmacists in the state. People coming in trying to get their buprenorphine and they weren't able to do that. So you can see how that can scale up to be a large problem. Again, in the survey, we saw again that the most common reason for not filling is the person's coming out of the geographic area, which is going to be more of an issue with telehealth prescriptions too. So if the provider and the patient are out of the geographic area, that totally raises red flags for the pharmacist.
Alicia, can I ask a question?
Yeah.
So I do find this a little interesting because, as physicians, it's like when I'm working, let's say I'm working in the ED, I can't say, oh gosh, this person's from Minneapolis. We only treat people from our county. Do they expect that patients don't travel like other normal people? Right? I mean, it's like, I find that really fascinating that there's even that thought that just because think about it, if there's 2 counties that are close, a lot of patients, because of the stigma, don't want to get it from their regular pharmacy because then the chatter goes around town, right? That they're on Suboxone. So they go somewhere else so that they don't, to me, that would seem like a pretty reasonable thing to do because of the stigma.
It does seem like a reasonable thing to do, but like I said, our state legislation, the STOP Act, says that it is a red flag if anybody tries to get a controlled substance from out of the geographic area. So what we do is try to encourage the pharmacists to document the reasons why they filled the prescription there. I'll talk about this at the end too, like what prescribers can do. But if you know that a person's going to go outside of their normal geographic area, you could be very helpful by putting that information directly in the prescription. Like, hey, this person's going to be traveling from here. This is a legitimate prescription, nothing to worry about. Then the pharmacist feels protected legally if anything were to happen.
Yeah,
So,
to me, that feels like that's discrimination against a particular group of patients.
yeah,
You say, well, you can't get your diabetes medicines
right.
here. You've got to go, if you go to another county, it's a red flag. That's just crazy. But
yeah,
okay.
to have it, and like national societies are calling for these red flags to be removed from legislation. But like I said, pharmacists are very nervous, like about doing things that, could be perceived as being illegal. And so they get very concerned about this. So it's a good thing to be aware of as a prescriber. And there are things that you could do on your side to help the pharmacist feel more comfortable with filling. So yeah, good point that you brought out. Other things to be aware of here with refusals is pharmacists at independent pharmacies are less likely to fill. They're more likely to refuse than pharmacists at chain pharmacies. And that's because there's this overall arching policy at chain pharmacies like your CVS, Walgreens, that usually say like, yeah, if someone comes in with this, then go ahead and fill it. Whereas independent pharmacies can have their own policies about different things. And this not filling or refusing more independent pharmacies has been found pretty consistently across a number of studies. So something else to be aware of there. 31% of pharmacists did perceive that there were buprenorphine ordering limits. And those with more negative attitudes towards buprenorphine are more likely to perceive that limit. And most cited wholesalers as the source of the limit, which is correct. So there are those. In addition to the survey, we did a secret shopper study specifically out in Appalachia, where we're looking at rural pharmacies. And we saw that pharmacists in rural areas would put conditions on filling new buprenorphine, specifically a Suboxone prescription in rural areas. Here, they wanted the patient or the prescriber to be in state. So we were on the border with Tennessee. Tennessee is only like 40 to 60 miles away, depending on where you are out in this area. So it's pretty close by. And sometimes prescribers in Tennessee won't prescribe buprenorphine. So people will come across the state line to get buprenorphine prescribed, and they'll want to fill from the pharmacy in the area as well. But if they're doing that, it again raises the red flags for the pharmacists. They're coming not just from out of the county, but they're coming from out of state. And should I fill this? They wanted to be able to verify the prescription, so they wanted to be able to talk to the provider about it. We did have an embedded pharmacy with an FQHC that would only fill for patients from on-site prescribers. So if anybody was coming from outside the FQHC, they wouldn't fill for them. And then these perceived ordering limitations. So they would say that they had a cap on the number of patients for the tablet formulation, but they could dispense films. And there are some pharmacies that when we call them would just say they're out of stock of buprenorphine. Do want to clarify, there is no DEA cap on buprenorphine orders. So there really is no cap. We talked with a legal expert about this. This does not exist. But the reason pharmacists perceive that it might be trickling down from the DEA is because the wholesalers have to include buprenorphine in their suspicious ordering monitoring programs. And people will say, oh, but the DEA released this message on their website saying like, oh, you don't really have to do buprenorphine, but it's not clear. It's nebulous. And people really tend to be conservative in these areas because of all the fallout that we've had from opioids in the country. So even though there's no DEA cap, there are wholesaler thresholds as a result of the suspicious ordering monitoring programs. And so it's related to increased monitoring, restrictions on ordering, blocked orders and shipments, and documentation of due diligence if you want to increase your order size. Now, the crazy thing about this is that each pharmacy wholesaler has its own algorithm that it applies for defining what suspicious is. And it's related to how many prescriptions that are non-controlled substances to the controlled substance prescriptions, right? And how it relates to other areas. So if someone gets out of whack in that alignment, it's going to be called a suspicious order. They do not communicate what this ratio is to the pharmacy. The pharmacy does not know until they hit it, and then it automatically gets reported to the DEA, and then the pharmacist has to go through a DEA enforcement or audit where they come and look at the pharmacy. So pharmacies don't know where these limits are because the wholesaler does not communicate with them. So the only reason they know is if they hit it. So yes, they do perceive that there's this DEA cap or wholesaler threshold, and this limits their willingness to take new patients because they don't want the DEA to come audit them. So here's an example quote. I've heard competitors say that we've reached a limit on how many patients they can fill buprenorphine for. We've had pharmacists talk about hitting this limit and how stressful it is for them. But see, this is the stuff that gets lost in data that you see like this. And so this is from American Society of Addiction Medicine. You probably saw these data. They came out with a report earlier in the year. So this is self-reported prescriber data, pharmacist refusals to fill buprenorphine prescriptions. So orange is 2022 and red is 2024. And so they'll say, look at this, we see so much higher percentage of pharmacies refusing to fill. It's like 76% versus 45. The thing that's getting lost in this kind of messaging is if you look at the number of reports, they dropped from 200 reports to 50 in 2024. So these data get reported, they get skewed. We've had people reach out to us in the state, like, did you see this? We're like, yeah, but look, it's down by 150 reports. So this is actually a good thing. So I just want to point out that the reasons that pharmacists refuse to fill, it's not just stigma. There's a lot of things getting wrapped up in this. This is a nice study here. This is a secret shopper study that was done in 11 states, looking at the buprenorphine naloxone combo product. They found that it was available in 48% of pharmacies overall. Now, pharmacies, can order it, but when they called, this is how many had it readily available. It was less available in non-metro or rural counties, and it was less available at independent pharmacies. And so they have it broken up that in the blue, it's states with high opioid overdose death rates. I think they took the average at the time. And if they were above that, they're a high rate state. If they were below that number, they're a low rate state. But what I'll put out here is just the amount of variability that you see in access here, same day access to buprenorphine. So 85% in Maine. So Maine was killing it compared to the other pharmacies, down to a low of 31% in California. So lots of variation depending on what state you're in. So, is someone saying something in the chat? I'm sorry, it's like at the very top. If someone wants to read something off, please feel free.
Yeah, there was just a comment that wondering whether there's a difference in the rules for like Walgreens in different cities.
Oh, yeah, that is a good question. So there are different district managers for like Walgreens, like regional managers in different areas. And I know, like, for example, and this is only talking anecdotally, like that were reported like that in the area that I'm in, Asheville, North Carolina, like Walgreens is awesome, right? This is what we hear from patients coming in. But we don't hear that so much from Walgreens. They're kind of out in the area. So there could be variation depending on the pharmacist. But in general, they have this policy that seems to facilitate like those getting filled more than you would at an independent pharmacy. But I bet you could see regional variation with a large chain. That's a good point. So when we look at pharmacist stocking perspectives, again, because you're like, wow, only about 50% were stocking it. They are discouraged by wholesaler thresholds. So they're not going to keep extra in there because they're afraid of hitting that threshold. And they want to prioritize what stock they have for established patients. So here's a quote. We were not able to keep the opioids in stock that our normal patients were getting. If we filled buprenorphine for these patients that would just come in for, 1 month, they would come. And then for 4 months, they would go to a different pharmacy. And so you can see how this would also mess with the pharmacy's algorithm. So if someone's coming in and just filling a controlled substance prescription and they're not filling their other prescriptions, that's going to start to throw that pharmacy more out of whack in the algorithm. Cost from the patient perspective has definitely come up. So this is a quote from a rural health department MOUD coordinator that had been working in rural North Carolina for 2 years. So the huge missing piece was their medication, and a lot of uninsured people couldn't afford it. So we had patients that were getting a couple days dose at a time and still backsliding to use meth because it's cheaper and that's all they could do. And you don't know what they were doing to even afford that couple of days of bupe. So we weren't feeling like we're able to help them the way we wanted to. Not every patient struggled to get prescriptions filled, but it was definitely the ones that really wanted to take advantage of the most affordable prices. It's not a cheap prescription. And this is from a patient who had been on MOUD for 2 years. So he said, don't start buprenorphine. I hate it. I wish I'd never started it. The prescribers try cutting me down, but they don't want to get you off. Not when you pay them $425 a month in office fees. And then when they cut you down, they give you the half tablet and you go in the pharmacy and you pay more for the half tablet than you would for a full tablet. It costs you money to try to quit bupe. It's completely against you if you try to quit. So that's a patient perspective. And I want to get more into these impacts on rural patients and share some more quotes in that space. So we know when pharmacies are unable to dispense buprenorphine, patients are at increased risk of discontinuing their treatment, using non-prescribed or illicit substances, emergency department visits, all-cause mortality, and overdose. And these are all things that we want to prevent. When we look specifically at impacts in rural Appalachia, patients tell us that cost and dispensing delays contribute to withdrawal symptoms. Some people saying that it's the worst withdrawal they've gone through in their life was off buprenorphine. So they return to illicit substance use and then regret initiation of OUD treatment, which you kind of saw in that previous quote. So getting more into these refusals, encouraging treatment discontinuation. This is from one of our interviews. What would you tell somebody else that got a prescription and was going to the pharmacy to fill it? Don't get the prescription. Just go to the methadone clinic and dose. Don't even mess with the pharmacy because it's a runaround. And then when you're on your medication every day, some days they'll make you miss because there'll be a mix-up or whatever. Then they'll make you miss your medication, miss a day or two, and that really throws you for a loop. You could be more at risk for overdose. So did that happen to you when you ended up having to miss some days of your medication because of the pharmacy? Yes, yes. Oh, hell, it's the worst sickness in the world. It's a really bad sickness. So this is someone who experienced withdrawal because they couldn't get their buprenorphine at the pharmacy. So we know that this is a really bad thing going on. In rural areas, we also see that these refusals really compound travel difficulties. It's not like you can just run down the street to the next pharmacy and get your buprenorphine filled. And this is a pharmacist who's talking about the patient's experience. So I have a patient, he's legit. I mean, he actually checked the website, that's our PDMP, and he goes to another competitor chain store and he fills his normal prescriptions and then he comes here. And I asked him one time, I said, you know, you're traveling roughly an hour away. He goes, I've gone to treatment plans where I live in the area, but none of the pharmacies even fill it. I said, did you ask him why? And he says, I went to 1 or 2 pharmacies, and even the one that he literally uses to get his maintenance medicine, they just said the pharmacist is not comfortable filling his prescription for that medicine, even though he's going to a legitimate doctor. He's using his insurance. He's, you know, not getting into anything. So here's a person that travels an hour each time they have to go get their buprenorphine prescription. Looking more at rural patient perspectives, people who are taking this medication are doing so to try to make their lives better. I've had friends who said, why should I even try to stop using drugs if I'm still going to be judged? So they've returned to using drugs instead of staying on Suboxone. My suggestion is for pharmacists to be supportive of buprenorphine. We have this quote really prominently displayed in our website, like our training website. So let's talk about resources to increase access. I mentioned the training that we developed. We co-developed it with rural pharmacists and stakeholders. It covers 3 main things, like ways to reduce stigma, addressing red flags that are in our state legislation, and overcoming ordering barriers. And so it's called Buprenorphine Understanding in the Pharmacy Environment. Our awesome co-development panel helped come up with that name. It has 4 modules, buprenorphine facts, roles of pharmacists, overcoming barriers, and then frequently asked questions and video examples. So here's something, we really want to put a bunch of practical tools on this website for pharmacists. And so we heard about those order size limits, those thresholds. We have examples of what they can do and how they can communicate with their wholesaler to try to advocate for an increase in their order size. And so they need to include information, including like the reasons for the increase, how much of an increase they're asking for, which prescribers the increase is coming from, and information like the prescriber's CEA number and practice addresses. So we have an example of how to do that. We've had some pharmacists have success with it, and we've had others where the wholesaler still won't increase their order threshold, even though they have all this awesome information saying why they would like to increase their threshold. We do encourage our pharmacists to reach out to their prescribers to document the number of OUD patients that they regularly send scripts for, so they can include that information when they're advocating for it. We also talked about dedicated dispensing agreements, which I'll show you a little screenshot with later. We do want to get into that stigma a lot in the training. So we talk about the importance of having the entire pharmacy team on board. Because if you're someone coming in to get your buprenorphine prescription, the pharmacist is not the only person you're going to be interacting with. You're probably interacting with a cashier, a pharmacy technician, and everyone that you interact with, you want to have a positive experience or at least be treated like any other patient coming into the pharmacy. We've had technicians tell us that the pharmacist really sets the stage for what should be happening in the pharmacy. So if a pharmacist is able to communicate the reasons why they support buprenorphine dispensing, why they think it's important, share non-stigmatizing language, then this can translate to the whole pharmacy staff and create a more welcome and warm environment. So we say, yes, talk with your staff about the benefits of buprenorphine, share why you personally support it, and tell them how it helps people continue with treatment. So this is the direct positive impact that you can be making. We also have videos to try to build empathy for patients, and I shared my sound. You might want to turn up your sound because it's a little low, but really short snippets based on people with lived experience sharing their stories with us.
One pharmacist saw my prescription and acted like she's a drug addict. It's humiliating and discouraging. When he didn't fill it, I went through the worst withdrawal of my life. It made me want to give up, but then I tried another pharmacy. They were so kind and just filled the prescription.
I had a pharmacist.
Like anyone else.
I live in Tennessee, but I work in Virginia. I had a pharmacist that I was trying to explain that the patient's behavior is because this is a chronic disease and we expect certain behavior. He said, you don't want to know what I think about that. he was refusing to fill the medication.
Yep. We do see that. I don't know which pharmacist it is, but anytime we send out a survey related on to anything harm reduction, we'll be talking about like, is there anything else you think we should know? And they'll say, this is natural selection. So yeah, you're gonna bump up against some people. I mean, those tend to be people that have been out, in practice for a long time. Maybe they've had some negative experiences directly at their pharmacy, because unfortunately, we'll have pharmacists. They'll be like, "Yeah, I'm going to sell non-prescription syringes." They will have some, people inject in the bathroom and overdose. Like that has happened to pharmacists right in our area, and then they get really discouraged from keeping to do that. And so, I mean, if the personal, like empathetic, like, be good to your fellow humans approach doesn't work, I found that stressing the economic benefits of having, people on buprenorphine tends to be a different angle that you can take. But it's going to be really hard when someone's entrenched like that. But hopefully you can find another pharmacy that's close by that does have more positive attitudes. If not, you just keep working on it a little bit at a time. They have a conception of, who the patients are. Don't know there's a lot of people who are coming in, holding down jobs, doing, staying on their buprenorphine. But we need to get rid of those stereotypes, I think, as we're interacting with pharmacists. And but yeah, sorry you've had that experience. We've talked to several people who have had that experience. So that was the patient video. What we try to stress in our training is that pharmacists are there to safeguard patients with opioid use disorder. And so these are the most common concerns that came up with our North Carolina pharmacists. They're concerned about filling for new patients, out of area or telehealth patients, out of area prescribers or new prescribers, prescription duration, all these different things. Some of these are red flags in our state legislation. So those are specifically out of the area patient, out of area prescriber, patients asking for the medication by name, imprint, or description, and then also cash pay patients. So these are listed as red flags that pharmacists have to check the PDMP. The other ones are not. So getting a new patient, what else? Prescription duration, which I showed you the quotes from, and then monoproduct prescription are not. So we go through those different red flags, which I'll show you in just a little bit.
I'm interested to know whether these red flags also apply to like benzodiazepines in your state. Just a thought.
I think it's generally like controlled substances. So yeah.
Because I rarely get, concerns about benzodiazepines, but the buprenorphine, if they get one extra or 1 minute early, it's like this huge thing. But
yeah, early refills are a red flag. And so yeah, they're particularly concerned about buprenorphine. I mean, I'm hearing things too, like even gabapentin is something that's starting to pop up on people's radars, like in different states are looking at doing the same thing for gabapentin. So I think you are going to see it from other types of medications as much as you've been seeing for buprenorphine, potentially, unfortunately. So,
Delisha, I have a question for you. I work a lot with jails, and what do you think about emergency kits, especially for rural jails? Some of them that I've worked with have been able to stock buprenorphine, and I think after listening to this presentation, it really comes from the discretion of the pharmacist that's in that rural community, allowing that to happen. Are there any stringent regulations or guidelines that prohibit that from being stocked in an emergency kit because it's exceedingly helpful, like in the middle of the night and, on weekends or holidays to have that within the facility?
yeah, I don't know a lot about jail-based distribution. I've worked with some people on advisory panels, and from what I've heard, it's been a really good thing. And I know they're able to do it with some of the jails here because, it's folks who are just getting released that are at the highest risk of overdose. And so that's why they've been able to justify being able to give out things like that. Also, at some of our jails, we have naloxone vending machines and things like that. So they're looking at other ways to get people it's good harm reduction, right? To be able to have the buprenorphine available, especially if there's going to be that transition to having to get to a pharmacy and get the buprenorphine filled. And I think that's if they're able to be on buprenorphine while they're in jail.
A lot of the jails that we work with in Minnesota, you know, they're started on it as early as possible and kept on it throughout the duration of their incarceration, so they're safeguarded upon release. But it's an issue because if we work with pharmacies that are only open, you know, Monday through Friday, no evening or weekend hours, and someone comes in on a Friday evening, like you're kind of SOL. So it'd be great if we could have buprenorphine stocked in an emergency kit so we can pull it if we need it, kind of thing.
Yes, I would be highly supportive of that. And it's funny, like I'm going to go exactly over that example in a few slides.
Sorry.
No, and it's what we tell pharmacists to do for safeguarding. So we try to give them like some example. Well, I'll wait. I'll talk to you about it then, so I'm not being redundant. But a lot of these things too, we try to encourage pharmacists because we saw a lack of communication with the prescriber being an issue, we encourage the pharmacists to build a relationship with their prescribers. And so we give them example phone script for contacting them, example fax or email templates. We really want them to establish a line of communication because if they trust you as a prescriber, they're going to be more likely to fill the prescription. And then here's just an example of some of the red flags or other concerns that aren't red flags. We tell them what they need to do. We really try to stress that this out of area patient is not a reason not to fill buprenorphine. Okay. Yes, you technically have to review the PDMP because of our state law, but you can just document why the person was coming from out of the area. Like no pharmacy would fill in their local area, and then the pharmacist is protected. And we've talked with our regional DEA agents about this because the pharmacists can be so concerned about legal actions. And they're like, as long as they're documenting why they did it and it seems like it's a legitimate thing, like that's what we're looking for. But there is variation between regional DEA agents as well. So, but the ones that we would talk to were really reasonable. Requesting early fills. So we go through about reasons why people might be requesting early fills. And if you're going to do an early fill, even though it is a red flag in our state, just document the reason why you're doing the early fill. And they can document that they're, you know, afraid that the person could be at risk of an opioid overdose if they don't provide them with their medication. So just put the reasoning in there. As long as the pharmacist is documenting that, they're going to be more protected. Again, this other thing, like talking about monoproduct prescriptions. Well, I think that might be on the next one, but requesting this, like people, they've had their one type of buprenorphine for a really long time, so they know what it is and they want to request it by name. But we also point out that insurance might only cover a particular formulation, so they're asking it for name because of that. Again, things that they can just document in the record. Here's the prescription duration thing. We try to bring them up to speed. Like some people can be on this chronically for a long time. Like not everybody's going to taper off the medication. And then monoproduct, I wanted to bring, like, because people are more concerned about diversion of the monoproduct. If you're doing a monoproduct prescription and there's some reasoning behind while you're giving a monoproduct prescription, it is super helpful for the pharmacist if you document the reason why on the prescription. Then the pharmacist is going to be like, oh, the person has an naloxone intolerance, or they've got an naloxone allergy. Like that's why they're getting a monoproduct prescription, makes them feel more comfortable filling. So here's that slide I was talking about and then the very top one, the most common one we hear is exactly what you say. So the person brings in a new script from an unknown prescriber at 4 p.m. on a Friday. Like, what do you do? So like, as the pharmacist, you're going to want to prevent the person from having a treatment gap, right? Because, you know, when they have a treatment gap, they're at increased risk of an overdose. What do? We tell them to consider filling a 3-day bridge script to get them through in the weekend. And then to call the prescriber on Monday or ask the patient to have the prescriber call the pharmacy, just get them through the weekend. Again, they can document this information directly on the pharmacy record as to why they did it and what the reason was. We also hear this about the missed appointment. So like they missed an appointment, they didn't get their new prescription, so they're coming in to get things early, things like that. But we just say like, okay, just do the bridge scripts when you can until you're able to get a hold of someone. And then, yeah, communication with providers. Pharmacists want to talk to prescribers and providers. So 100% that we interviewed think that it's important. And they're more reluctant to dispense without an established relationship with the prescriber. And they want to discuss prescriptions that are coming from out-of-area patients or new patients, or if you're a new provider, directly with the provider. So here's an example quote. I'd like to have a conversation with the prescriber about their plans, like if they're just going to keep the patient on bupe or if they're planning on tapering them off slowly, or what's going on. Because on our side of it, when we get prescriptions, all we see is a prescription, you know? We obviously don't see the patient notes or know anything about what the doctor's thinking. So because they don't have access to an electronic health record, they don't have the full picture. So all they see is what comes on the script. So the more useful information that you can put there or communicate to the pharmacist, the more comfortable they'll be filling. We really, if you take one thing away from this as a provider, what I encourage you to do anytime you're writing a new script for buprenorphine is to call the pharmacy or have staff call the pharmacy to make sure that that pharmacy is accepting new patients before you send the patient there to pick up the buprenorphine. This can prevent a lot of trouble for the patient, especially if there's few pharmacies in the area and they have to travel a lot. So just call and verify that they're actually accepting new patients. You could have had several pharmacies in your area hit their threshold and they can't take any more patients. So it's really important to know that before you send a script in for a new buprenorphine prescription. Like I said, we talked about documenting useful information on the script, like reasons for monoproduct or out-of-area patients. If you're new to the area, so if you've shifted or you're writing for patients in a new area, reach out to the pharmacist and just introduce yourself. That develops that trust and again makes the pharmacist more comfortable to fill for you. And then if you call a pharmacy and see that they've hit their threshold, offer to write a letter of support for them to advocate for a threshold increase with their wholesalers. We've had several pharmacies be successful for that, and then they're able to take in more bupe patients, and it's just good for the community. Other things that can happen are dedicated dispensing agreements. These are pretty straightforward. They're memorandums of understanding. They're MOUs. They state what the purpose of the MOU is, the dates that it's in effect, the roles and responsibilities of the prescriber and the pharmacist, termination clause, principal contacts, and signatures. So that's all that's in there. And in our training, we put it on there. So we learned about this when we were doing our research from a health department that had a dedicated dispensing agreement with a pharmacy. And so that dedicated dispensing agreement meant that if any patient from that health department comes in with a bupe script, the pharmacy is going to fill it. We heard positive things from the health department, we heard positive things from the pharmacy, and we heard positive things from the patient, because the patient feels like, oh my gosh, if I go here, I know I'm not going to get a runaround. I'll always get my bupe filled. The pharmacist knew, okay, there's this many patients that are going to be coming in each month from the health department, so I know I'm not going to hit my wholesaler threshold. And then the providers know that their patients are taken care of. So these are good things to look into. Like I said, we have an example up there, and it's just really straightforward. It's a lot smaller than you think it would be, so something to explore. Also pointing out that professional societies are calling for more partnerships between pharmacies and providers. So we've got some from American Society of Addiction Medicine in July 2024, National Association of Boards of Pharmacy and National Community Pharmacists Association also in 2024. They're calling for these partnerships for people to advocate together for eliminating those red flags for bupe. You all were talking about how ridiculous out-of-area patient is to be a red flag. So let's see if we could get rid of that. Let's see if we can get rid of cash pay patients for patients who don't have health insurance. If we could get rid of for monoproduct prescriptions, addressing telehealth concerns, because that has come up. Our Walmart chain here in North Carolina, pharmacies, will not fill telehealth scripts. That's their policy. So if someone has gone in and gotten it, they won't do it. So being able to go through and advocate for changes like that is important. And then continued advocacy for scheduling changes, like for buprenorphine, because it's been shown to be so effective. So just in summary, if we want to increase buprenorphine access, we're going to have to work at multiple levels. So we need to clarify those wholesaler policies, advocate for descheduling, eliminate those red flags, improve communication between prescribers and pharmacists, help them advocate for increased order size, look into dedicated dispensing agreements, have interventions that are effective at reducing stigma. And then on the patient side, we need to help patients identify those prescriber pharmacy pairs or just pharmacies where they're taking new bupe patients so they have a more positive experience. So I know we have some time for questions, so I'm going to stop sharing screen. If you prefer to send a personal message, just shoot me an email and be happy to answer that. I'm going to stop sharing so I can see you all.
That was absolutely wonderful. Thank you so much, and so appreciate hearing other folks' perspective that also work in this space. Super helpful. We do have a couple comments in the chat. One says, is the pharmacist's job to approve of the physician's diagnosis and treatment plan?
No, their job is to check the PDMP to make sure that those red flags or that the person's not like going across to multiple pharmacies trying to fill prescriptions, those kind of things. So they don't have to verify, they do not have to verify the diagnosis.
To me, it's like really kind of a touchy issue because I mean, certainly we get patients in our clinic here in the addiction clinic where it's a Friday and you don't have the information you want. But it is one of those things where if you deny treatment and something goes wrong and somebody dies, I mean, that doesn't look good. I think it would be really difficult as a pharmacist to not fill a buprenorphine product knowing that full well that a patient could overdose and die. I mean, it just seems like the liability would be significant.
I think they think more on the liability side of like, I didn't do my due diligence as a pharmacist for verifying the scripts because I couldn't get a hold of the prescriber. So if anything happens then that way, like it's diverted and then the person is arrested, like they're going to come back to me. So I think they're looking at it that way. Now, we have lots of pharmacists who do fill these scripts and are trying to get more patient, being able to fill. We have lots of great pharmacists that are doing that. But occasionally you run into the one like the person talked about from Tennessee. So.
A quick question, because I recently had a bad experience where it was a pharmacist telling me point blank they weren't going to fill buprenorphine because they just weren't comfortable and they didn't know the patient. And I called to try to push that order through and say it was okay. This patient had been out of the medicine for 4 days and was acutely withdrawing. And I kind of brought that liability up. I said, well, are you worried about the liability if this patient returns to use or if they overdose? And she just kept repeating that the manager, whoever was in charge, said, no, they're not comfortable. So we settled on a 3-day bridge. She said the patient has to go somewhere else. And I said, well, they don't have transportation. So would you like to direct them to the nearest ER? And I guess going back to that liability question, is there some sort of protective act, anything saying, can you really just deny because you're not comfortable with a legitimate prescription with the diagnosis and such?
A pharmacist has the right to deny any prescription that they're uncomfortable with. That goes for birth control, Plan B is over the counter now, but it goes for different, any prescription that they are not comfortable filling, they don't have to fill.
That kind of feeds into Danielle's question in chat. Did they take the same approach with a prescription for a fentanyl patch? I kind of see, on that note, it's like there's so many more high-risk substances that I feel like we're more okay with dealing with in society.
Yeah, I haven't heard anything about the fentanyl patches specifically. I just know generally from working with pharmacists for over a decade, they're just so concerned about legal things. So if they thought there was a chance that the fentanyl patch might be diverted or they don't know the prescriber who wrote it, or if it's a legitimate thing, they can get really nervous about that, about filling it and just wondering if they're going to be liable if anything happens, if someone diverts it or whatever. It's such a diverse group working with pharmacists, and they're like, yeah, like I said, we're doing a methadone survey right now, right? And like, will you want to participate in a pilot, to work with in a medication unit model with an OTP? We have like 120 pharmacists in the state raising their hand, like, yeah, we want to do the pilot. And then we have people like that are on the survey, like, there's no benefits of dispensing methadone, like, does it matter? Like things like that. So it's just your whole gamut of attitudes on the subject.
Dr. Wilcox asks, are pharmacists getting the same education as physicians are about buprenorphine and how it's being used to treat chronic disease, similar to like a patient with diabetes, for example?
Yeah, I think you'll see less of this as, our older pharmacists retire and you've got these new batches of students coming through pharmacy school, because there are a lot of pharmacy schools that address that and teach like the benefits of buprenorphine and MOUD. So I think you'll see like in younger folks too, they are particularly like, yeah, we should, we're educated on this and we should do this. We don't have any required like MOUD education credits in North Carolina. That might vary for other states, but we have some really good optional programs for them to take if they're interested.
I do think it's really interesting how, I mean, if I think of physicians, policemen, nurses, and everybody, and I would probably include pharmacists in this as well, if they have a friend or a family member who's been down this road, there's so much more helpful. And actually, I have a pharmacist in mind that I deal with, and he has been nothing short of fabulous with the situation we're dealing with. And it's been very complicated, but sadly has this in his background, right? And he gets it. And I think, the stigma can really be disabling to a system. So, yeah, it'd be better if they got it by education than by having this type of issue occur in their family, right?
Mm-hmm. Yes.
Other questions for Delisha before we let her go? So fabulous talk.
Yes, thank you so much.
Thank you.
I appreciate that you're bringing some of this to light. I'm going to be a new prescriber in a treatment center. And I'm thinking, I would have never thought to reach out to the pharmacy that we use. All of our people are coming from all over the state, right? They're coming to treatment because they can't get it. Well, that's just where they end up, is in a rural area in northern Minnesota for treatment. And the pharmacy that we use is certainly not going to be accustomed to the potential level of prescriptions that I'll be soon sending to them, because that is our devoted pharmacy. So giving them a heads up that, I'm just grateful for the perspective.
Yeah, that would be great if you just give it like, hey, you might be seeing X number of additional patients. Like, are you comfortable? Feel like you can accept that level? Or there are things that I can do to help you if you need to increase your wholesaler threshold to be
right. Because if they're not willing, then it's a big problem. I'm still planning on prescribing, and that's our pharmacy that our organization has used for, generations. So it's just additional things to think of ahead of time.
Yeah. Amy, too, as you look to send these people back to their communities and they need buprenorphine, don't be afraid to reach out to us. I think we know just about everybody everywhere who's kind of doing this, and especially some of the really good prescribers in different areas. So we're always happy to help you track those people down. So
thank you.
All right. Well, I think we're all done. So Delisha, fabulous talk. I learned a ton today, so I really appreciate it.
Thanks for inviting me to join you, and good luck, and I hope you have some good pharmacy experiences.
All right, everybody.
Thank you.